ඉස්සරහට එන්නේ කර පැත්තට යන්න තව ටිකක්. කවුරුත් නැද්ද මම? ඊට පස්සේ ඕකෙන් හරි. ආයෙත් ඊට පස්සේ වහන්න මට මේ ඉදා මේ ස්පීකර්ස් දෙක කියනවා මම ඒ දෙක දාගන්න දන්නේ. මේ ලයිට් එක නමලා ලයිට් එක දාන්න. තඩේ වෙනවා කියලා බලන්න. තඩේ නැහැ. නැතු හරිනේ. Good. Okay, let's start. I do what? After we have it. Carrot. Whatever it is. Just before starting, just a little bit of something that is not something that's good to do. Seen anything like this before? When you see a picture like this, what comes into your mind? You see, it's a group of, you can see that it's in Africa. Children, they always do things like this. They always act in groups. And basically, what do you see here? if by any chance one of these children get up and go, what will happen to the sun? Circle will move. So this is very common in Africa, especially in these savanna areas where they always go in groups. Okay, and that basically protects them. And it's not only unity, it's just that you look after one another. That's the other issue, especially. No, there is this story in there is this story about these children all working together. In Africa, they always go in bunches. Whenever they want to do something, they go in bunches, groups, and they always work together. So this was it had come down from their parents as well, and then they basically, one of these European anthropologists wanted to basically come and see why do they do this time? So he wanted to check with them. And then they basically, he went and did a small experiment. He took a basket of fruits. And it's a savanna desert where you get one tree in the distance and then another tree in the other side. He kept the fruit basket on one side and then he put the group of children on the other side. And then he said, on the count of three, I want all of you all to run and get the basket. And the person who goes there first will get the basket. So he counted to three, 1, 2, 3, and all of us, all the group ran to the basket, holding hands. And they all reached the basket at the same time. Ultimately, what happened? Everybody got the basket. So in their language, it's called Ubuntu. Ubuntu. And they were asked, why did you do that? And they said, how can one of us be happy if all the others are sad? That's something that you can always I mean, even in Sri Lanka, children, they do work together, but as you become adults, and just imagine this group, taking a photograph like this. So, that itself now everybody is taking selfies and group photographs and doing all kinds of things. Just imagine doing something like this. It shows not only that's a different ability altogether. Not like working single. So what they feel is that if by any chance something happens to me, there is a crowd of people who are backing me. So I'm protected. But that's why they work. Good. So it's good to work in a group and a community who have a common share. When is the last time you all had a group session? I mean, you all have these sports events and things like that. It's always good to go like that. Okay, we come to the subject. The brain tumors and their effect on the vision. The tumors can occur anywhere in the body. But when it comes to the brain, how does it affect the vision? And you all have been coming because of the things. And this is, you can see a huge lesion in the brain. And what do you think a person will come and present to you with when you have a lesion? They come and get they will always have very subtle symptoms. Sometimes, most of the time, they are asymptomatic. unless it impinges on the visual part. So that's why it's important to know about the visual part. I think I showed you last time also. This is how the vision goes from the eyes to the visual cortex. The signal. That's the left eye. This is the right eye. And you can see the right eye, the temporal visual field goes like that. There's a green line. And then this comes to a place called the optic chiasma, and the temporal fibers go straight away. In the left eye also, that side goes like that, comes to the optic chiasma, and it goes straight away. But the nasal fibers on both sides, they come to the optic chiasma and they cross over. And then they go from there to the optic chiasma, it goes to along the optic tract. This is called the optic tract. And it goes to a nucleus called the lateral geniculate body or the lateral geniculate nucleus. And then from there, it goes along this optic radiation through the temporal and the parietal lobes into this occipital cortex. It is right there. And that is where all the visual things are basically composed. So you have to know this pathway to find out whether there is anything wrong. If there is anything basically affecting this pathway, and the moment it affects the pathway, you start to find out some kind of a problem. And the basic thing that we normally do to find out if you have a problem is to do a visual field test. Now, visual field test is done for glaucoma and then for this type. And the visual field test will tell you exactly where the problem is. And if there is a tumor impinging on any of these areas, it will show up. And that is what I'm going to basically talk to you about in this tumors. And then I'll be talking about the tumors, metastatic tumors. And then we'll talk about two subjects, which is not neurological, but myasthenia gravis and Parkinson's. So in the first half, just want to go through this. Common tumors, their location and the visual effects. Now, this is the pathway that I showed you. What I want you to see is that those are the two eyes, the left and the right eye, and you get the optic nerve. The two optic nerves coming onto this place called the optic chiasma, and then from there it goes along these optic tracts to the lateral geniculate bodies on the either side, and from there the optic radiation goes to the occipital cortex. Got it? So if there is a problem or something is tumor is basically impinging on one optic nerve, this is what you will see in the vision. Right? That means that optic nerve is not working, therefore that part is blind, and this part, the right eye, left eye is okay, so the eye is that's okay. So if there is an optic nerve tumor, which is normally gliomas and meningiomas, these are benign tumors most of the time. You get a monoocular visual loss. Monoocular means like that. Do a visual field. Have you seen visual field being done? How do they do that? Open the graph. Visual field they can show lights right now and you press the button. So likewise, you map out these things and you get in the one side, you can't see at all the other side you can. So this is a monocular visual loss. So the problem is here. Got it? Problem is in one optic nerve. That is, then we come to the optic chiasma. Optic chiasma is over here and it decussates, as I said. And I told you that this is very important. Whenever you want to find out whether there is something wrong with the optic nerve, there are three things that you have to know. One is it, it, it transmits light, it transmits color, transmits pupillary fibers. So therefore, if there is a problem, first thing is the visual acuity will go. Then you may have an apparent pupillary conducting defect, and then your color vision will be impaired, and then there will be brightness sensitivity, and the visual field defect will be there. So, if you want to know anything about the optic nerve, this is the things that you have to check. What are they? Sure. Pupil is very. So then we come to the area called optic chiasm. That means that this is the optic nerve, and then this is the optic tract, and then there is this chiasm. If you imagine a tumor that is impinging on this, that's interesting. This is the type of visual field defect that you will get. In one side, it's impinging on the left eye optic nerve, you get a central scotoma, and there are fibers that come deep into this area and come out. Therefore, you get a junctional scotoma on that side. So that is if you have a tumor impinging on the optic. Then, if there is a tumor, which is normally called, these are all benign tumors, a craniopharyngioma, that basically pushes from the backside onto the optic chiasma, you get a visual field defect like that. On both sides, it's basically in a lower quadrant, and then gradually as it impinges, it goes on to that. And the most common thing that we see is a pituitary tumor. Pituitary gland sits right under the chiasm. If that, let me show you that. Right. Say the most important thing that I want you all to know is that when you do a visual field and you come across a neural defect, it always basically doesn't go beyond the vertical line. Now, in a glaucoma patient, you can have this type of visual defect goes like that. But here, it doesn't cross the midline. It basically affects one half, this half, but it doesn't cross the midline. The moment you see that type of thing, you know there is something wrong with the nerves. It's a neural thing. So that much, moment you see a visual field test and you can see a very well demarcated, not crossing the midline, that is definitely you can, without making an idea, you can say that is something to do with the nerves. It's something is impinging on that thing. But if it crosses the midline, then you have to see something there. That's not neural. So that type of visual field defects occurs. And then, as I said, if that is the optic chiasma, the pituitary lies right over here. Pituitary gland is the main gland, the hormonal gland, which lies right underneath. So if it basically grows upward, it's going to impinge on that optic chiasma, and you get a very specific visual field effect, which is called, if you call it, if it's only on one side, you call it hemianopia. Hemianopia. Only that side is gone. So if it's basically impinging on that, you get what we call a bitemporal hemianopia. Now this is over here, right? It's number 3 because it's impinging from bottom. And then bitemporal hemianopia, the moment you see that, you know it's a pituitary problem. And the visual field is on both sides, not on the nasal side, but the temporal side. If this is the right eye, so this is the right eye and this is the left eye. So it's on either side, and this is called a bitemporal hemianopia. And this is basically pit gland tumor. Moment you see this type of thing, that's a pituitary gland tumor. So that is a visual field effect, basically touching on the chiasm. And this is how it looks like. And then you come to the optic tract. That means this part, this part. From the chiasma to the lateral geniculate body, and you get what we known as left homonymous hemianopia. And here it is like that. It's only on one side. Again, respecting the midline, doesn't go beyond the midline, but it's only on that side. And that is called a left homonymous, means in the same side, hemianopia. And that's how it looks like. Homonymous hemianopia, and its same side visual field loss in both eyes. That involves the optic tract. Okay. You got it? Are you all with me? Good. So it's over there, optic tract, optic tract. Then we go to the optic radiation. Optic radiation is over here. When you go to the optic radiation, it goes off in 2 directions. Therefore, you only get what we call a homonymous inferior quadranopia, means only a quadrant, same side of the visual field loss, but both inferior quadrants are in. And that may be due to the optic radiation tumor impinging on the parietal or the temporal lobe, or the fibers are going in both directions. And that is the optic radiation. Then it comes to the visual cortex. When it comes to the visual cortex, it has a different thing. You get a homonymous hemianopia with a macular sparing. The macula is normally okay. But the other side, that there is a total visual field loss. Something like this. But the macula area is fine. And that's how it looks like on normotomography. That's called the homonymous hemianopia with macular stem. So you can see we are basically depending on the visual field to find out whether a person has a brain tumor which is impinging on any part of the visual pathway. And that is the occipital lobe tumor which is impinging on somewhere there. And you get a left homonymous hemianopia with macular square. So the clinical signs that you are basically seeing is clinical signs the optometrist might observe in the brain is first thing is the vision. You can see that the vision is down. Then if you do the visual field test, see the visual field test basically in not crossing the midline. And then you check for the color vision and the pupil. And if the thing is getting involved with the pupil, the disc, you can say like something like intracranial pressure, or then you get a disc swelling, and then later on, at late stages, you might get a optic atrophy. That means the optic nerve has died. So these are the things that you will basically come across when you are examining a patient, and that will basically trigger, is there something wrong? Not in the eye, but in the brain. Good. And always remember these three, the pupil, color, and light. Whenever you are thinking of, if you have a doubt, just check those things and see whether any of those things are basically done. And the things that we basically use is the visual field test. We can do an OCT, that means optic coherent tomography, just to see that you all have seen an OCT. And then check the pupils if there is a relative afferent denervated pupil. And you can, if any of those things are not, if you are seeing something neurological, you do an MRI. So these are the things that we do, but basically we rely on the visual field test. And then if there is something wrong, all of a sudden what you see they will come and say, sudden unexplained visual loss. And then bitemporal or homonymous මේ වගේ මොකක් හරි field එකක් loss එකක් තියෙනවා නම් which is not crossing the midline, then you are thinking something is there. Then persistent headache. You know, any tumor that is inside the brain will cause a severe headache. Sometimes they start vomiting. එහෙම ලොකු මේවා එකක් තියෙන headache එකක් තියෙනවා නම් you have to do an MRI. There's no question about that. And sometimes when you look through the ophthalmoscope, you might be able to see papilledema or optic atrophy. And sometimes they complain of double. So if you see any of these things, that is time to refer. You all are basically interested in referring, finding out that there's something like this is not normal. They have to go. Sudden unexplained visual loss, and they have go and ask them to do a visual field test, and basically they have this type of thing, headache. And then also they might have diplopia, and when you look inside the eye, there is papilledema. So these are red signs, the red flag signs for you to refer a patient. Good. Now, just in summary about the brain tumors, I told you about the optic nerve. You get monocular visual loss. Where the vision is lost, the pupil is affected, the color vision is gone. Then it comes to the chiasma. We talked about bitemporal hemianopia. That's that. And it's almost always a pituitary gland lesion. If you see the visual field like that, bitemporal, not the nasal part, but it's not crossing the midline. Got it? Then optic tract, homonymous hemianopia. And then in the temporal lobe, you get superior upper quadrantic hemianopia and parietal inferior upper quadrantic hemianopia. And in the occipital lobe, you get a homonymous hemianopia that is like this with the macular square. So all with so that's all I want you all to basically remember. Just remember the three things, test and the visual. I don't want to go into big details. This thing has, if you want anything, it's all there in the handout, any other. So this is what I want you to remember: optic nerve, the chiasma, the radiation, the tract and the radiation and the occipital. Good. I think that is okay. Then we come to metastatic tumors. Metastasia means you have a tumor somewhere else in the body and it spreads to the eye. Now, this is the commonest thing that we see when it comes to ocular tumor. You see something inside the eye, it's not originating, most of the time, it's not originating from the eye, it's from somewhere else. So it spreads of cancer cells from a primary tumor elsewhere in the body or its surrounding structure. So it has come out from somewhere else, and it's the time that you see a patient with secondaries in your eyes, his lifespan is very short. By the time it reaches the eye, that means the time is going to live is very short. It's the most common form of intraocular malignancy in adults. That's what we come across. About last year, one of my very good friends died, and just about 3 weeks before, he came with secondaries. And then I knew that he will have. He also knew about it, but he didn't want anybody else to know about it. That's a different story. But by the time you see that, like, typically occurs in patients with a known history of systemic cancer. So if you see them, then you have to inquire about whether you have any other issues in their span. And this is how they present. This is how more than that, I saw a lot. You can see the tumor somewhere there. Can you see that? It's under the retinal vessels. And you can see, if you do a fluorescein or a angiograph, you can see the staining on that. So that's a secondary metastatic tumor from elsewhere. And this is what I saw in my friend. It was all over. Me. And basically, it was a tumor from the prostate. He had it for a long time. And by the time he came, it was just like this. Normally, it comes from the lungs, the breast, the gastrointestinal tract, the kidneys, or even from the skin. So any tumor from the skin can also come like that. And the choroid is the most common site to go, because the choroid, the nerve, the retina is on top and the choroid underneath, and the choroid is full of blood vessels. So it spreads through the blood, and therefore, because of the high flow, it makes it vulnerable to hematogenous spread. And what you see is this type of yellow creamy lesions, and you can see the blood vessel going over it because the retina, the retinal nerve fibers are in the top. This is in the choroid. You see that? When you look at that, you can see the blood vessels in front. That means the lesion is underneath that. So that those are ocular metastases, usually from the lungs and the breast. Breast cancer is very common to get this type of thing, and the lung is the most important. Good. And what do they come and complain? Blurred vision, visual field defects. Sometimes they say, pain. And flashes and floaters, photopsia, things like that floating around, and pain and diploma. And here also you can see a lesion underneath the retinal nerve fiber layer in the choroid. And that's how they present. The moment it affects the macula, the vision goes down. If it's somewhere here, they don't notice anything at all. That's the macula. If it basically comes along that side, then the vision goes. So in fundoscopy, you see this yellowish subretinal mass. So how do you diagnose? As I said, you can do an OCT, a B scan. Have you all seen B scans? B scans, yeah. That gives a very good, you can measure the size and thickness, and you can do fluorescein angiography and then find out what type of lesion it is. And the role of the optometrist is to be vigilant that the patient is a known systemic cancer patient. And you have to document it and refer it. Whether and provide supportive care, because that is the most important thing. You have to basically help, and talk with the patient and be with him, because that's the most important thing in this business. Because most of the time there is no cure. So the ocular metastasis, the key takeaway messages is that ocular metastasis is the most common intraocular malignancy coming from the breast and the lung. It's painless visual loss. Doesn't come with pain, not pain hemodulity. Visual field changes are there. Early detection is very important, and then you have to know that it is coming from elsewhere. And it's normally managed with radiation, systemic therapy, and sometimes targeted systemic treatment. It requires an urgent referral for evaluation. So these are the things that I want you to basically remember, that it's coming from elsewhere, and most of the time it's coming from the breast and the lung. Good. Then we think of I told you that it comes into the choroid, spread of cancer cells to the choroid. Again, it's occupying that lesion, that area. Painless, blurred vision, often unilateral. That's the funny thing about it. I don't know why. It comes only twice. And it doesn't happen. And so we use these things, the OCT, the B scan, and the FFA. And we manage with radiation. We give external beam radiation, we give chemotherapy, which is very, very, I don't know. It's something, if somebody can go through chemotherapy, I think he's a hero, because it's so much painful. And you can give anti-VEGF injections into the eye, and then you have to refer for oncology. And this is a patient who has been treated for secondaries. This is the tumor in the beginning. You can see this is the B scan. You can see the B scan tumor over there, and that's how it looks like. And once the treatment starts, it starts to regress, and you can see that it has regressed from here to there. So this is the regression part. It will leave a scar, but this is the real tumor, and this is the regressed. Good. Okay. Now, in breast cancer, we give a drug called tamoxifen. Even after removing the breast, we give them tamoxifen to prevent it from recurring. Tamoxifen is sometimes used even for 5-10 years. And tamoxifen itself can cause a retinopathy. It can cause a retinopathy. And it's a toxic retinopathy caused by a long-term use of tamoxifen. It's an estrogen receptor modulator, and it's used in breast cancer. And this is how it looks like. That's the optic disc, and this is the macula, and you can see this beautiful, it's like some seedlings around it. So this is how it looks like. Unfortunately, most of the time, sometimes it can be reversed by stopping it. Sometimes it leaves this thing. but I have not come across that much. I have seen patients who have been on tamoxifen for ages, but nothing has happened. But in some people, even after 6 months or so, they start having this time. Tamoxifen. And the cause is the toxic damage of the retina, especially the retinal pigment epithelium is affected. Now you can see the tamoxifen retinopathy over here and here. And when you do an OCT, you can see that that area there is a edematous area. And it's basically affecting the retinal pigment epithelium, which is over there. That is the area that is. So tamoxifen basically goes and binds onto this retinal pigment epithelium layer. And that is how the tamoxifen retinopathy occurs. Good. And what do you do? Basically, you discontinue tamoxifen. You tell the oncologist, I think it's time to stop. And you give a small, then you monitor the function of it. No specific treatment. Some people give these anti-VEGF and steroids into the eye, but I don't fight like that. That's tamoxifen retinopathy. Good. Any questions? No questions. Have you all known anybody with tumors in the eye? Never seen anything like that? Anybody? No. Good. Unfortunately, I don't have any questions today. So shall we go into the next part? Yeah. The other two areas that we are going to do is myasthenia gravis and this Parkinson's. What is this? What do you see in this page? Anything wrong with the right or the left eye? What eye is affected? Left. What is wrong with that? What is wrong with that? Drooping, isn't it? See, drooping eyelids, you have to always think of this step. This is called myasthenia gravis. MG. MG. Myasthenia gravis, for you to know, is that normally when it is a problem in the connection between the it's at the neuromuscular junction. In the normal neuromuscular junction, if that is the nerve and there is a plate called the neuromuscular junction plate, this is the gap between the muscle and the nerve. That gap, the impulse is transmitted through these chemical known as acetylcholine. Now, acetylcholine is, once the impulse comes here, acetylcholine is released from this plate and it gets bound to acetylcholine receptors on the muscle. And from there onwards, the impulses go down. That is the normal thing. When a nerve fiber comes into the muscle gets the message through this acetylcholine. Now there are acetylcholine receptors on the muscle. In certain diseases, they produce antibodies against this receptor. And therefore, the acetylcholine cannot bind to these receptors. And therefore, the signal is not transmitted. And there is reduced transmission. This is what happens in myasthenia gravis. And it can affect lots of body. It can affect lots of muscles in the body. Starting with the drooping eyelids, and there may be blurred vision, slurred speech because the facial muscles are gone, trouble in moving the neck, arms and leg weaknesses, difficulty in chewing, and then the facial expression becomes very bad. And then there is difficulty breathing at the very latter stages. It comes very slowly. I've seen patients living for ages. So the clinical features that you see in the eye is mainly the ptosis. Bilateral, sometimes symmetrical ptosis that affects the women much more than the males, especially the young women. And they also can develop diplopia because the extraocular muscles are affected. Extraocular muscles. And there is the other sign called the Cogan sign. When looking down and then looking further, there is a small flutter. And I'll show you these two. And then when you gently close the eye, causes the subtle opening of the. So ptosis is the main thing, and diplopia is the other. So they come. You can see that the eyes are drooping, and then they come with double vision. As is ptosis, you can see the ptosis on that side, and then there is diplopia, intermittent diplopia. So, and it occurs in young people, mind you. And sometimes the droopy eyelid, there is also blurry, and then sometimes they complain of burning sensation. There is only that these may be the only signs of ocular myasthenia. And when it affects the other parts of the body, it can go into all the voluntary muscles. They find it difficult to swallow and difficult to breathe. It can be in the eye only, but it can be in the other parts of the eye, brain also. But mainly think of myasthenia when you see a ptosis. The eyes are drooping. It's one thing that you have to think of myasthenia. What we do is there are different tests to check this type of thing. There is a very simple test called the ice test, not the ice that we are talking about these days, but this is just ice. You put a ice pack and it will. And then there is this confirmatory test called hydrophonium, and then there are electromyography tests, antibodies to acetylcholine, which we do now, and then we do a CT MRI. Because most of the time, myasthenia is associated with a gland in the chest called the thymus gland. And the thymus gland may enlarge. And most of the time, we do thymectomy or remove the thymus gland, and they have myasthenia. This is how it works. I'll show you to the ice pack is applied to the affected eye for 2 to 5 minutes. This is before applying. And then once they apply the ice pack, it improves. Can you see that? So this is an ice pack. Let me show you a video of this. So it is the transient improvement of ptosis due to the cold decreasing the acetylcholine esterase breakdown of acetylcholine at the neuromuscular junction. Let's see this. I hope this plays. A day when I think we'll have to go out. Go this. On බලන්න. So it's important that we basically do this eyes test if you are basically thinking of myasthenia, because it basically tells you, gives a very quick thing about myasthenia. The other thing that they mentioned you would notice that the fatigability, the more you basically move that around, it becomes. And that is the other thing about myasthenia. More you move it around, it basically tends to fall down. So then the real test is that we give them what we call anticholine esterases, and this is a very risky this thing. It's an injection. You have to have all the necessitating equipment with you before doing this, because the patient's heart can stop, and that is before the injection of euphonium, which is also called the tensilon test. And this is before giving the injection, and this is after giving the injection. You can see that the doses has basically. So the treatment, there is no such cure for this, but basically we give them anticholine esterases. They are oral tablets, but they have to be given thrice of 4 times a day. Sometimes we give them steroids and azathioprine. And then I said about the thymus, we remove the thymus gland, and that improves myasthenia gravis. So basically, we think of acetylcholine esterases or physostigmine. So what is more important for you all is that if you suspect, as optometrist, if you suspect, document the findings. You basically measure the distance. And then see that there is fatigability and variability. As you saw it, he held the stimulus up, and then you can see the thing coming down. That is called fatigability. And always check for any systemic involvement and be cautious, especially if you all are using these contact lenses thing. Myasthenia people are, they cannot use this contact lenses. And because because of this problem of grouping. And then if you are planning on surgery also, you have to have a very good deviator action. Good. We come to the last topic. Who is this? You all know this guy. Have you all ever heard of him? No idea who that is. He was a hero in nowadays. Anybody known about this guy? Obviously, he's a boxer. He's a world champion. No idea. Muhammad Ali. Yes, great. Muhammad Ali is the first black man to become the world champion boxer. He was a legend in his time. He was unbeaten for so many years. And later on, he got lots of bangs on his eye. Later on, he developed like, and this condition is known as Parkinson's. And that's what we are going to talk about. Parkinsonism is also a problem with the neurotransmitter in the brain, which is called the dopamine. Dopamine. Because you get a lot of bangs that dopamine receptors don't come into the. Parkinsonism is a disease, a chronic, progressive, neurodegenerative disorder. Neurodegenerative. And this is how we basically spot a patient with Parkinson's. There is a resting tremor. They keep on tremor. And when you hold their hand, it becomes rigid and then all of a sudden. That is called cogwheel rigidity. And they have that classic gait of shuffling. And they have postural instability. That means they are basically crunched onto the ball, right? So there is postural instability. If you see a patient like that, you cannot miss. I'm sure you would have seen in the practice also when they come, you can initiate them and then they go and then all of a sudden stop. And they have the tremor. It's very difficult sometimes when you put them on the street lamp or the auto refractor to keep them there. So it affects it's a neurological disease. There is rigidity, there is postural instability, bradykinesia means there is shuffling gait, and there is the tremor. So this is due to a pigmented dopaminergic neurons in the brain, substantia nigra. There are neurotransmitter called dopamine, and there is a reduction in the dopamine from this area. And that is the reason for Parkinson's. And dopamine levels are basically reduced, and there is no neurotransmission, and that gives rise to Parkinson's. The thing that you see in the eyes is, can you see his eyes basically staring? They don't blink. They just don't blink. They keep staring at you. So reduce blinking and ocular crisis can look and then look at one place and wait. There is reduced convergence. The two eyes don't come together most of the time. And the brain stimulation, there will be pupillary abnormalities in the eye. So these are the signs that you will see in a patient when they come for an eye test. The moment you see them, you can see them. The way that they look, basically staring. And then no expression. sometimes they find it difficult to open the eyes. And this is what we call apraxia of the eyelid opening. I can make a better. I'll show that in another apraxia of the eyelid. So they cannot open the eye. They can close the eye, but find it difficult. And it's very, very, very disturbing, when you want to open the eyes and you can't open your eyes. Good. Yeah, is. So, so that is called apraxia in the eyelids because they cannot open the eye. So the treatment, that's Ali, is monoamine oxidase inhibitors, which is called levodopa. Levodopa, they are dopamine agonists. They try to bring in more and more dopamine into the system, and anticholinergic agents. So those are the treatment. They are oral products that you have to keep on taking until the rest of your life. And the improvement is very, very, they gradually go down. Good. I think we are done for today. Good. Any questions, any problems, anything that you all want to see? There are loads of things in the note that you can go home and read about. Any other issues that you want to clarify or anything? So what we did today was basically we talked about the tumors and how it affects, and we talked about the visual field. And basically, I talked about the bitemporal hemianopia, the pituitary gland. Mind you, I have so many relatives and people who have pituitary gland tumors. They have been operated. Lots of my cousins, and they are quite okay after doing that. And then I talked about the other lesions in the thing. And then we talked about choroidal metastasis. And then we talked about tamoxifen retinopathy. And then we went on to talk about myasthenia gravis. And lastly, we talked about Parkinson's. So Parkinsonism, we had that tremor and the rigidity. And in myasthenia, you saw how the eye stress really did. Good. That's about it. Thank you very much. Next lecture will be my last lecture for you all.